There's a saying that goes, if you've met one person with autism, you've met one person with autism. And that means exactly what it means. Every person with ASD is different, just as how I'm different from you, and Catherine, who just presented, and the next 3 people who are also presenting about autism. What I mean by this quote is that autism affects people. This is a study about people, and this is a study for people. My name is Jasmin Wang, and I've been doing research the past 5 to 6 weeks at the Koegel Autism Center, which is directed by Dr. Vernon. Together with my mentor, Anthony Osuna, we've been looking at ways to optimize ASD treatment experiences for ethnic minority families. Autism spectrum disorder, also known as simply autism or ASD, is a neurodevelopmental disorder characterized by repetitive behaviors, restricted interests, and difficulties in social communication. Early intervention for autism has been shown to be associated with greater positive outcomes, but unfortunately, ethnic minority families tend to receive treatments at lower rates and are diagnosed significantly later than white families. We believe a possible reason for this disparity is the therapy's appropriateness to the family's culture, beliefs, and family structure. By assessing community needs, we hope to learn more about certain inadequacies in current treatments in order to culturally adapt treatments to be more appropriate for the target community. Our objective for this study is to understand the unique cultural needs of an ethnic minority mother with a child with autism in order to optimize her treatment experience. In order to achieve this, we interviewed a Filipino mother with a child with autism. Due to HIPAA and patient confidentiality, I cannot reveal her name or any personal identifiers. So for the purpose of this presentation, I'm going to call her Valerie. Valerie is a 40-year-old woman with an 8-year-old child that was diagnosed with autism at 18 months. She identifies as a mixed race of white or European and Asian or Asian American, and she immigrated to the United States from the Philippines after college. She lives with her husband and her son, and because both she and her husband work full-time, her husband's mother also helps out in taking care of the child. The first step in our interview analysis process was obviously to conduct the interview. Our interview was semi-structured, which means that we had a set list of questions, but allowed the conversation to flow naturally. Our interview lasted approximately 70 minutes and was recorded. The second step was to transcribe our interview onto paper. We stuck as close to the dialogue as possible and ended with a total of 21 pages of text. Our third step is thematic coding. Thematic coding is a process to transform qualitative data into quantitative data by encoding this information as themes. A theme is a pattern found in the information that describes and organizes and possibly interprets the information. Our thematic coding was inductive, which means that we started with the data and came up with themes from there. My mentor, the other RMP student, and I separately coded the interview, and then we came together and mutually agreed on 19 codes. Then we went back to the interview a second time and coded specifically for those 19 codes. And finally, our last step is to analyze our results. I found that 11 out of our 19 codes related specifically to my research question of the optimal ASD treatment experience and only used excerpts from those codes. This is a thematic map. We went through our interview excerpts for codes, and then we turned those codes into themes. As shown here, my codes were organized into the 3 sub-themes of cultural differences, family roles in caregiving and therapy desires. These 3 sub-themes all relate to the central theme of ideal treatment. I'd like to make a note that codes can relate to multiple themes, as shown by the code barriers to treatment, and that ideal treatment and cultural differences are both codes and themes. So let's look at our first sub-theme of cultural differences. Valerie didn't feel like she fit in with the typical parent demographics in the city that she lived in. She mentioned specifically that feeling of otherness prevents you from going to places. Together, we discussed how ethnic minorities might feel more comfortable if the therapist speaks in their native language, even if they are fluent in English. People naturally feel more comfortable with others that share a similar background as them, and this concept applies to therapists as well. Furthermore, certain therapy interventions go to the client's house for therapy. Valerie wasn't really comfortable with letting therapists into her house on a regular basis, especially at the beginning of the therapy process. She grew up in a culture where it was normal to provide snacks or clean the house for guests, and she wasn't sure if she needed to do anything special for her company. Being clear about the treatment process and being aware of cultural differences is obviously important. However, Valerie also highlighted that therapist qualities of being patient, compassionate, and empathetic really helped her settle into therapy more comfortably and quickly than she would have otherwise. Our second sub-theme is family roles in caregiving and therapy. I mentioned previously that Valerie's mother-in-law, or the child's grandma, helps take care of the child. She's in charge of the child's treatment and takes care of his after-school activities, and she serves as a sort of bridge between the parents and therapy. Valerie is grateful that the grandma is there to help, but she's also frustrated that she can't play a more active role in her child's therapy. Communication between providers and caregivers is always important, but especially so if the parents can't participate directly in the treatment themselves. Valerie highlighted that specifically when talking to therapists, she wants regular updates, goal-oriented conversations, and information about therapy strategies and accommodations. Furthermore, certain therapy interventions also require a family member to be present at the time of therapy. Valerie is relieved that the grandma qualified for this role, as otherwise they would have lost out on this treatment opportunity. Therapy should have more flexibility in who can be involved in the treatment, as some families might only have a trusted neighbor or babysitter to rely on. Other accommodations should also be provided as necessary. And finally, our last sub-theme is therapy desires. One of Valerie's main therapy desires was synergy between her son's home team, which is CDPL that provides floor-time therapy, and her son's school team, which provides special education services at her child's elementary school. It's common for families with a child with autism to combine multiple treatments together, which makes it logical to want some sort of communication or cohesion between therapies. Valerie also brought up that she wants more social group opportunities for her child, as they are beneficial not only for a child to have more social interactions, but also for the parents to have some sort of community support. She's asked specifically for therapists to be the ones to provide this social group opportunity, and also to have something more available during the weekends or even during the child's school lunch hours. And finally, Valerie brought up the topic of parent therapy. She actually went through parent therapy twice, as she didn't have a strong support system, especially at the beginning of the child's diagnosis. She acknowledges that it can be difficult to admit, yes, I need therapy myself, but she talked about how it was actually really beneficial for her. Optimizing ASD treatment experiences also includes treatment for parents. It's important to keep in mind that parents and other caretakers are directly affected by a child's diagnosis, and that they need their own support system and help as well. To summarize, 7 conclusions were drawn from this interview. But if there is one takeaway from this study, it would be that therapists should always make sure to take in the patient's ethnic and cultural background into consideration. This study is only the first step in assessing community needs, and our study should be replicated with more participants in order to see if our results are truly representative of the larger community. With more data, we can eventually inform future treatment intervention development so that we can eventually adapt certain treatments to be more effective and accessible for ethnic minority families. And in the end, our goal is simply to help people. Again, this is a study about people, and this is a study for people. I'd like to acknowledge the following people on this slide, and I am now open to questions.